Hello, everyone. Welcome to our APCIS Online 2020. This is the second day of our webinar. I'm Sung-ho Kim. I will moderate our webinar with our great surgeon, Dr. Chang Lee.
Thank you.
Yes, yesterday we had a wonderful time with many participants, and I bet today we can have a more exciting time because we will have many interesting and challenging cases today. Before we start our case presentation, I would like to introduce you our panelists. First, Dr. Frank Ng from UC Davis, California. Dr. Please raise your, can you see? Okay. And next, Dr. Omar Galal from Saudi Arabia. Omar, okay, raise your hand. And Dr. Satoshi Yasuguchi from Japan, Nagano Children's. Okay, thank you. And Dr. Jisok Bang from Korea. Oh, thank you. And how about Sakamoto?
두 사람 아직 안 들었어요.
He may be late. And Dr. Jaegon Kwak from Seoul National University, Korea. And Shingo Kasahara.
네.
He's also late. And Marhisham bin Chemud from Malaysia. Hi. Okay. Today we have 9 cases, 6 interventional cases, and 3 surgical cases. I would like to call on our first speaker, Dr. Frank Ng, who is my old friend and is a very famous pediatric cardiologist in the United States. He will present 2 cases. I think after first case presentation, we have a discussion for 3 minutes. After then, continue second case. Frank, are you ready?
I'm ready. Shall I share the screen?
Okay. The first case is standing on critical core in neonate. It may be a very interesting case. Frank, please.
Okay, can you see my screen?
Yes.
Okay. So again, I want to thank Sung-ho and your team for inviting me for this always fascinating APCIS. So I've always feel privileged to be part of this team here with you guys. Okay, I have 2 cases to present. The first case, this is, I'll start with an 11-day-old female who presented to the emergency room with poor feeding and decreased energy. In the ER, the baby was worked up for sepsis. During the lumbar puncture, the baby became apneic, mottled, and then bradycardia, and then required CPR. Now, the baby was intubated, epinephrine was given, the heart rate eventually came back to 130s, but the pulses were considered to be weak. On chest x-ray, there was cardiomegaly, and an echocardiogram performed showed a severely diminished levely function, and a coarctation was noted. So again, this would be a situation of a critical coarct in a neonate where the original diagnosis was missed at the time of birth. PGE was started, and patient actually ended up with multi-organ failure. Given this poor function, actually the patient went on emergent ECMO cannulation for support at that time. So here's the example of the left ventricle with the function. You can see it was horrible at that time. And there is the coarctation. You can see that there's a very tight stenosis, and at this time, I think the the PG hadn't been started, so the ductus was not open yet. So you can see the initial X-rays. You see the 2 cannulation, the ECMO cannulas on the X-ray on the right-hand side, and then 2 days later, you notice the extra body fluid in the anasarca that developed as a result of the initial insult. So about a week later, now of course at this point the patient was not making any urine, so there was anuria, the liver was horrible, and so we had to wait and for him to have some recovery. So luckily, about a week later, on ECMO, on PGE, the function had improved significantly, and you can start to see that the PD had opened, the aortic coarctation had improved to some degree. So the question is, what do you do at this point? Now, at this time, we know that the kidney is not working. He's on dialysis. There is a severe coarc. The question is, do we go for surgical repair? Options would be, should we do intervention? If we're going to do intervention, are we going to do angioplasty? Are we going to stent? And if we stent, we have to ask ourselves, what's the approach? So are we going to go femoral artery, right carotid, left carotid, axillary, right or left? Now, we had a big discussion about this. Now, at this time, the patient had weaned off ECMO. Now, the ECMO was, the VA ECMO was placed and the cannula was actually put into the right carotid. So after the repair, we were worried that the right carotid may have some damage. Now, coming from the legs, it's probably that we will end up losing that femoral artery. So the options would be to go to left carotid. And if we did that, and if there was still injury to the right carotid, we now would potentially risk injury to both carotids, which I think would be catastrophic. So we elected to go to the axilla, and looking at the echo, it seemed like the right axilla could be a reasonable place to go. So that's what we did. So just to review a little bit of anatomy, you see a volunteer with the pictures in there with the needle, and basically it's easy to pick out the deltoids. It's easy to pick out the head of the coracobrachialis, which is part of the biceps head. And of course, there's the axillary artery. What's important is that you notice the brachial plexus goes on both sides of that artery. So you got to be really careful not to miss and cause some brachial injury. So using ultrasound, you can actually pick out the axillary quite easily. Here it's pulsating. We press on it, and you notice that we can't compress it all the way. And in fact, you can see us pushing down to see where the needle might begin, but that's the artery. And here I actually was able to show the tip of the needle go through. You can see that needle go through, and eventually there's the tip of the needle. So at this point, the blood is spurting back, and then we're able to run a wire through that. Put a little sheath there, and you take a quick picture to make sure you didn't extravasate. You can clearly see that we're inside the vessels. Put a catheter through, and you see that very enlarged brachiocephalic artery. There's flow into the distal arch and even some into the PAs, and you see the ductus in the descending order. So we know we're in the right place. At this point, the wire goes posteriorly down the descending aorta. We put a pigtail in there, and we can take a picture. You can see clearly that the distal arches has a coarctation there. In fact, the tip of the pigtail is inside the ductus. You see the edge of the ductus there. And of course, the ductus is open because of the PGE, so you don't appreciate the coarctation as much. But just to show the stills of that, so the arch at that point measure anywhere from 4.1 to 4.6 millimeters. There's a coarctation that is not as obvious as it was before because of the PGE. You see the ductus, the MPA, and then the descending aorta that is of normal caliber. So here we are running a stiffer wire down to the back of the atrium of the descending aorta. And this is a Boston Scientific Express stent. Now, this is bigger than the coronary stent, but certainly not something that can get to adult size. This can get up to about maybe 9 millimeters. And at this time, after a discussion with the surgeons, we knew that we could not put an adult size stent in, but this is a bailout just to get them out of trouble. The hope is that we can fracture this later on. And there was a 5 millimeter diameter stent. So here we are. Once we have a good position, we slowly inflate the stent, and you see that the stent go up. And then this is the picture afterwards. So again, we were able, again, it doesn't look so bad because earlier with the PG on, the coarctation wasn't so bad, but clearly it expands the distal arch, avoiding the left subclavian, also crossing the coarctation into the descending aorta. You still see some ductal flow that is now right to left. And that's the diameter at this point measured anywhere from 5.1 to 5.35 millimeters. So it's about the size of the distal arch itself. In fact, it's a little bit bigger at this time. And this is what the echo looks like afterwards. You can see that stent is well positioned in that distal arch, and then you see that the flow to the left subclavian looks nice and open, and there's good flow down the aorta. So again, when the echo showed that the function actually was good, at this time we were able to stop the PGE. And here's the X-ray. Initially, you see how large the heart is. The next couple of days later, there's anasarca with a lot of third spacing. It starts to get better 2 days later on ECMO and on dialysis. And then, of course, it starts to get better. So it took about 2 weeks before he was stabilized enough where we decided we can go in. And basically, this is right before the stenting. You see there was an effusion on the right. We put the stent in, and it took another 2 days before it normalized. So at this point, the kid did well. He's still in the hospital and started on peritoneal dialysis. And the hope is that he'll probably end up getting a kidney transplant. But more recently, he started to make some urine. So the hope is that the kidneys will still recover and that he won't need a kidney transplant. But all the other systems have normalized at this point. So I think that we were able to get the kid out of trouble using the axillary technique to place the stent. So that ends this first case.
Okay, congratulations on your great successful stent implantation on neonate. Yeah, are there any question to Frank? I have one question. So you could successfully implant the stent on core, and what's the next plan? While the baby grows, stent still there, and you can open up bigger balloon. How large?
Well, this is not a coronary stent. So I know that most coronary stents can get to about 5.5, and then that's the limit. This stent can get up to about 9 millimeters. So not the normal bigger adult size, but it can probably get him to about 2 years old or something in that range. Now, depending on how big he grows and so forth. But the plan right now is to fracture that stent when we get to that point, and probably end up using a covered stent. Again, the hope is that we can get him to that size. At the time when we made this decision, it was a team decision, and we knew that this has a limitation in terms of the size, but the kid was really sick, and the surgeons thought that he was too high risk to take to the operating room, especially because the kidneys were not working. So we'll see. Well, maybe in a couple of years, we'll present this case again and show the follow-up.
So have you ever experienced the unzipping of a coronary stent?
We have done that. I don't like doing that. So if I could try to put a stent into using the adult size, I would prefer to that. But in a case like this, where you don't have much choice, we just thought that this would be the best option for him. The trick to unzipping is don't use a very big balloon all at once, because if you use a very big balloon, the stent starts to foreshorten, so it becomes like a ring. It becomes impossible to break. You have to go 1 millimeter at a time, and then if you do it 1 millimeter at a time using high pressures, you can unzip this.
Okay, I see. Any other question or comments from panelists?
Can I ask you guys, would you have gone through the axillary, or would you have tried from the femorals?
I have never tried the axillary access, but femoral may be okay. You used the 5 French sheaths, right?
Yeah, it was a 5 French sheath. Now, we actually have a sheath called a slender. It's actually an adult sheath, and basically it's got the same outer diameter as a 4 French, but it's a very thin wall sheath so that it actually can take a 5 French catheter. But the problem is that it's so thin that it can kink. So once you put it in, you have to put a tegaderm to prevent it from kinking. But it has the same outer diameter as a 4 French. So that's worth looking at. I know the adult guys have this on the radio for the radio access.
Okay.
Hi, this is Toshi speaking. I think I prefer to use for that actually. And then my question is regarding to Frank. Do you consider the stent implantation immediately after the stabilization of the patient status by the ECMO?
Say that one more time, please, the question.
Well, my question is, when do you, do you consider the stent implantations immediately after the stabilization of the patient status by the ECMO? instead of waiting for a couple of weeks?
Well, I guess the option could have been waited and see and keep him on PGE for a while. Certainly, the function had improved, so therefore there was not an emergency to go forward with the procedure. But I can tell you that even now the kid just started making urine, and this was almost a month already. So the question is that can the kidneys handle the surgical side of things? And I don't have a good answer for that because that's a surgical decision. But when we were speaking to our surgeons, the hope was that we can get him past this stage and deal with the stent later on. Would you have waited enough time to then take him to surgery? And if the kidneys were not working, would you still proceed just using dialysis as your backup?
Okay. You can continue your second case. Second case is valve-in-valve of Edwards Sapien valve on 23 millimeter Carpentier-Edwards valve. Yeah.
Okay, so this is the second case. This is a 25-year-old male. Actually had the history of an omphalocele repair as an infant. Also has cardiac congenital heart disease consisting of double outlet right ventricle, dextral position, had a surgical repair, and then subsequently had an RV2PA valve, prosthetic valve placed. It was a 23 millimeter Carpentier-Edwards or Paramount valve. We know that that particular valve has an internal diameter of 21 millimeters. That was placed back in 2004. Then end up with all kinds of atrial arrhythmias and sinus bradycardia, and it basically was diagnosed with a sick sinus syndrome and had a pacemaker placed in 2008. Then had balloon valvuloplasty due to valve stenosis 8 years later in 2016. So at the time of us seeing the patient, he now has valve stenosis with a peak gradient of 57 millimeters, mean of 36 millimeters, as well as moderate PI. There was also moderate tricuspid regurgitation noticed. So there are again two serially regurgitant valves. The RV was moderately dilated and hypertrophy and had basically what was thought to be low normal function. Interestingly, he had hepatomegaly, so much so that he was referred to the adult hepatologist. They did a liver fibroscan and had a stiffness score of 47 kilopascals. And again, that's a way to grade the degree of stiffness. And based on that scoring, he had stage 4 disease, which was cirrhosis. So the plan at this time was to try to put a new valve in there and hopefully open up the stenosis and stop the regurgitation, and perhaps that could help with the venous pressures, and also as to do a transjugular liver biopsy to see how bad the liver was. So this is just fibroscan reports. The impression was that this was basically a stage 4 disease considered in the range of cirrhosis. So that's pretty bad. So here's the RBgram. You notice the dextral position of the heart. There's the Paramount valve noted with some calcium. Catheter is in the RV. And the function is not, actually doesn't look that bad qualitatively here. But you see that there is some TR notice on the lateral projection. Now you also see the pacemaker wires. Now what's interesting is that when you have pacemaker wires, you have to be very careful on how to get your catheter through to the PA. So here's a good example. We're trying to get through here, and if you don't pay attention, you can see that the tip of the catheter can actually pull down on the pacing wires. And if I wasn't paying attention, I can easily think that I can dislodge that. So we stopped doing that. So then, of course, we rotated, finally got it in, and here we are in the MPA with an angiogram. And you notice that there's a fair amount of pulmonary insufficiency. I would say probably in the moderate range. The proximal LPA is a little bit on the small side, but there was no gradient, so we left it alone at this time. This is an aortogram. Now, for some reason, there was a little bit of a staining into probably a little stitch a leak there, but it doesn't extravasate. So, but you see that the two coronary arteries are not near the bioprosthetic valve. Usually we don't worry so much about the coronaries when there's a bioprosthetic valve because that ring is quite solid. But if we think that we might have to crack it, we still have to take a good look. So my impression at that time was that both the right and left coronary arteries were far enough that I think we should be okay. So once we take this picture, we decided not to do a selective coronaries. Now we came back and started to think about how to put the catheter in. And we get in this catheter, and the question to the audience is, what is this? You know, this looks like an unusual venous collateral, and it happens to go into the kidneys and then comes back out of the renal veins. I have to say, I have no idea what this collateral is, but I think that I've seen other types of venous anomalies associated with omphalocele patients. And so I think it's important, if there's a history of omphalocele, you might come across some of these very unusual venous structures. But here we are in a tiny, it's a very posterior vessel. I don't think we're in the true IVC, but it connects into the kidneys. So very interesting here. Okay, so we finally get back in the true IVC, and here I am doing a test inflation. You notice that this is, well, I should have used more contrast, but there is a big distance between the edge of the balloon and the edge of the ring, so that the balloon diameter was 15.5 in the AP projection, 10.7 in lateral, while the ring is anywhere from 23 to 20 depending on the projection. I think the AP projection in this situation was more accurate because it's more in profile. So it is a 23 millimeter perimount valve, but the internal diameter should be 21, but clearly there's some stenosis there. So then the question is, what kind of valve should we put in? Now he's a pretty big boy. The options that we have, I know you guys have other options here, is the Melody valve, which has the diameter size of 16, 18, 20, 22. I've been able to push it up to 24. And then now that we have the Sapien valves, they can go up to 23, 26, and 29. And if you add a few extra millimeters, you can maybe push up to 30, 31, and it still be competent. But those are the standard sizes. So given the fact that this is a pretty big guy, the thought was that maybe we'll put in a larger, the Sapien system, a 23 millimeter, and see how that might fit. So this is, I got this from Edwards, and this is just a cartoon animation showing how this is done. Now this is not the Sapien 3, this is the Sapien XT. The design is similar, the way it's brought in is the same, so I don't think it's any different, but I want to show you a couple of things that are unique to this particular valve. So initially, of course, you take your sizing balloon, you put it in, and you inflate it within the prosthetic valve here, and just to get a size idea of the size that you have to work with. Once you do that, you deflate it, take it out, and then you prepare the valve. It gets crimped onto the balloon, but the balloon is actually distal to the stent. And then when you go through this system here, this is done internally. Now, we don't do it this way. We actually put a sheath in, but this is basically you cranking it to bring the center of the balloon onto the stent. So then with that, that's how they're able to minimize this delivery system. So with that, you then put the whole thing across. Now, this is done pretty much sheathless. So there has been some reports of causing tricuspid regurgitation and damaging the valve because it's not protected by a sheath. We've decided that this is, we prefer not to do this sheath, so we actually would put in a sheath. These days we have the dry seal sheath that can go up to 26 French in diameter. So we actually have a way to do this traditionally using the protection of the sheath. So with this in mind, here's the 24 French dry seal. It's a 65 centimeter long sheet. You see how big this is, it's huge. And we put it right up to the edge of the valve here, and here's just watch very carefully. What's happening is we're rotating the knob here so that we can slowly bring the balloon back down to the stent to center it. And basically, you'll see it slowly crank down to the top marker, which you don't see the bottom very well, but it's right here. You want to get the stent right up to the tip. And then here, oops, sorry, go back here. So here we are getting the tip of the stent centering between this marker and this marker. Now, unfortunately, the other marker here was hidden a little bit, so you don't see it as well. But basically, now the valve is centered on the balloon, and the whole thing can be pushed up to the valve now. So, oops, sorry, wrong way. So here we are pushing the entire system. Now you see that it's all inside the sheath. So we're having protection from there, especially there's also pacing wires in there. So I didn't want any problems with having the stent catch on the pacing wires or getting some damage on the tricuspid valve. So here we are getting just underneath the valve. Now I'm okay with pushing it through. And we're just centering it. This valve actually, when it inflates, will foreshorten from the bottom up. So we have to pay attention to leave a little space on the back end so that it can foreshorten upwards. So here we are. Now the second part is to pull the protection, the stent protector inside and pull it back. So now that you've freed the entire balloon and stent away from the delivery system, it's only on the wire at this point. And of course, we're going to have to adjust the balloon. Right now, you see the lateral, the stent is too far out. What's really interesting is I want to show you that it's really important to make sure the three crowns are at the same level. So you notice that the middle crown is a little lower than the two edges. So at this point in time, we want to change our angle just to make it in perfect profile and see that these are minor, like 20-degree rotation of the AP, and that gave us a little more profile. So I think it's really important to get the best profile you can, especially when you have a bioprosthetic valve to help you. So once we get that into position, that's the valve, that's the position. You notice that the valve is up at the lower third is inside the crown itself at the base. So once we're happy with that, in fact, we pulled it back a little bit. So I'll show you that, see, this is actually about third below. You watch this, this will slowly make its way up. So therefore, what happens is that it does foreshorten upwards. But right now, once we put it up there, it looked very stable, and it looks very happy on this. Now, of course, this is still low pressure of the system here, but it's implanted in a nice, stable way. This is what it looks like once we're fully inflated. But you notice that there's a gap between the valves. So therefore, there's some tissue there. The only way to open that up is using higher pressure balloons. So initially, we went up with a higher pressure. This is what we call the true balloon, TRUE, and it can go up to about 20 atmospheric pressures. And we went in with a 23 millimeter true balloon first. So again, this is just to inflate it some more. And then we did another inflation and basically try to tack it on as hard as we can. And then finally we went up with there's still a gap there at the time. So finally we're going up there. We took a picture first. There was actually still a 25 millimeter gradient there. So we thought that was not enough. There's still a little PR, but I think that could be because of the wire and because of the catheter there. So here's the higher pressure 24 millimeter atmosphere. A high pressure true balloon. Now I want to watch at the very end of this, watch that arrow, it pops. So it's going to be at the very end. Just watch this spot right here. And we're just slowly cranking. See that jump? I gotta go with it. I'm gonna shorten this and you'll watch this. Watch this pop right there. Right there. So just to show you that it's a very subtle drop in the pressure in the balloon, and then it just unzips like that. So with that in mind, we took that picture, and again, there's still a little PI here with two catheters in there. We weren't too worried, but at this point in time, there was, I think, a 7 millimeter gradient left there. Took a picture from below, and it looks a lot better. And you notice that the gap here is a lot less than what it was before. So we came back, and then we just took another picture on the IVC. Again, you notice that we were no longer in the collateral. The other collateral was actually much more posterior, closer to the spine, but this is the true IVC. Mm-hmm. And then, of course, we still had to finish out with the biopsy. And again, you notice that this pacemaking wire has been there for a while. So there's some area of stenosis here, which is not uncommon. But we're able to get down there. We take a picture of the hepatic veins. And we always want to go to the largest lobe, which is the right hepatic vein on the posterior part. You see the posterior in the back. By now, you see there's a kidney there. And the nice thing about doing this afterwards is that you have the shadow of the kidney to make sure that you don't hit the kidneys. Now, the biopsy system is very stiff. So we had to put a super stiff wire in there. And of course, there's a lot of tortuosity. So we had to be very careful when we push the system to make sure that it follows the wire and the wire does not buckle. But eventually, we make our way across the heart and down to the IVC. See that there's some turns that we have to negotiate. Finally, we're there. And the key thing is to rotate it anteriorly, because we know the kidney is posterior. Again, I can show you the outline of the kidneys. Want to make sure you're away from the kidneys anterior. You see now the needle goes up, and when you push the button, the cannula goes over and it takes a core of a liver muscle, a liver biopsy. I didn't take a picture for you, but I can have, it looked like little tiny worms of tissue there, and that gets sent to pathology. We took 3 samples here. Again, as I said, the key thing is to make sure you avoid the kidneys and make sure you don't go too far to the liver capsule. And then we do this 3 times, I think. We got 3 samples. Each time you have to rotate it anteriorly to get this biopsy. Then just go slowly, and then once you get the needle out, you push the button to have the cannula go over the needle, capturing a rim of tissue. So then at the end, we take a picture. You can see a little bit of the edges where we've gone into the kidneys, but so far you don't see any extravasation, so we're very happy with that. And then afterwards, it actually turns out that the biopsy showed mild sinusoidal dilation and congestion. So it's not as bad as what the fibroscan was. So again, this was a result of long-term high venous pressures from the PR and the TR as well. So hopefully the liver will improve over time. So that's here's the 2 valves measuring back to back. You see down the internal diameter is in the 20 millimeter range as opposed to 10 previously. So I think that is the sizes there, and here's the ultrasound afterwards, looking at the stent. Now he's a big guy, so the images weren't very careful. You can see there's a little bit of regurgitation there, but the flow wasn't too bad and not a whole lot of turbulence there. So here's the 2 valves on X-ray close up to see that. You can see that it's flared, and it's probably hard to tell, but there was a little bit of a separation on this part of the ring further down here. I think that's where we cracked it. Open it up some more. And you can clearly see it looks bigger than before. Mm-hmm. So that's it.
Okay, thank you for your excellent cases. Any questions from the panels? You used the high pressure balloon, true balloon, not an Atlas one.
No, we just have the true balloons. I think the Atlas can work as well, but the true is what we have, and it can go up to 20 atmospheric pressures. And it comes in 20, 23, 24, 26 millimeter diameter. So I think that it's a very good balloon, but I think it works the same as the Atlas.
Okay.
Actually, we tend to use the Atlas Gold, which is a little shorter shoulders.
Okay. Actually, yesterday we had a session of percutaneous pulmonary valve implantation. At that time, only the Polestar, Melody, and venous P valve, not Edwards valve. So, you may have experience Melody and Edwards valve. What's the difference, and what's the merit of yeah?
We're used to using the Melody only because that came first. But actually, I think the Edwards valve, it's a little stronger, so you don't have as much of the fracture potential. It can go bigger. So like I said, it can go up to like 29, even push it to 30 millimeters. So for the larger size patients, that's a good option. We also know that the Melody valve, it's a good valve, but there's a slight increase in the risk of endocarditis. We know that it's the same with the surgical Contegra valve as well. So again, we don't know the reasons for that, but it may have to do with the bovine jugular valve. But I have to say, I've gotten very used to the Edwards valve as well. The crimping system is a little different, and we do have to use a big sheath, bigger than what we normally would use for the Melody. But for the big kids, it actually turns out to be quite straightforward once you use the sheath. Previously, when we did it sheathless, we were always worried about damaging the tricuspid valve. We had one case where the valve did not seat properly, and we had to pull it back. Luckily, we got out, but I can see how if it's not protected with the sheath, you can damage the tricuspid valve. In this particular case, because the patient also had pacing wires, I wanted to make sure we had good protection.
Excellent. Any other questions? Huh? The one interesting question from the Soik Jung from our hospital, he asked about the biopsy, liver biopsy. How about after the liver biopsy, is there any bleeding issue?
Yeah, so it's a great question. So of course, of all the complications, bleeding is the important thing. The key thing is to make sure you know where the liver capsule is. So I always want to make sure that there's a 3.1 centimeter needle that comes out. So you always have to make sure the tip of the sheath, you have 3 centimeters to give you that room. So that's the one thing, to make sure that you're not too deep into the liver, so that the tip of the needle does not hit the liver capsule. That's number one. Number two, you also don't want to make sure you hit the kidneys. Now, some people do the procedure at the beginning of the procedure because they don't want to give heparin first. I actually find that I rather do that at the end. Even though the patient has heparin, I can clearly see the shadow of the kidneys, so I know how to avoid it. So I do think that that is a consideration, but we've not had a bleeding problem yet. As long as you don't hit the capsule, it bleeds back into the liver, so it doesn't matter. And we always take a picture afterwards to make sure. Now, if you did cause injury and got in the liver, you'll get a peritoneal bleed, because this is a needle with a cannula in it. So if that happened, you can always put a little plug in there and close up the tract if you need to. I'm not had to do that. But it's no pain there, because if you come in from the outside using percutaneous technique, there's actually very painful. This way, if you do your cath, you can do the biopsy at the same time, and patients do not complain of any pain.
Okay, thank you. Okay, if you have no question, I would like to move on to the next speaker. Next speaker is Dr. YuHao Chen from Shizuoka Children's Hospital, Japan. He will talk about the utilization of ADO-II against PDA with severe pulmonary hypertension. Dr. Chen, please.
Thank you for your introduction. And I will share my screen. Wait a minute. Okay. Can you hear? Can you see my slide?
Yep, perfect.
Okay. And good afternoon, everyone. I'm YuHao Chen from Shizuoka Children's Hospital, Japan. I'm very happy to attend this web conference and the case competition. And because the time is limited, I'll start my presentation now. And our cases are about the utilization of ADO-II applying to patients with PDA with severe pulmonary hypertension. So as you know, ADO-II is a double disc device, and the discs are much larger to make the device highly stable. And it has 8 different sizes and can be used not only for PDA, but also for other various shunt lesions, such as VSD or coronary fistula, or something like that. And this is the recommended sizing chart. But as you know, the recommendations in this chart are a bit larger. So a smaller and shorter device is likely to be chosen. And I'll show you 2 cases using ADO-II for PDA with pulmonary hypertension. So this is our first case, who was born at 36 weeks of gestational age and developed severe asphyxia at birth. PPHN developed, and she also suffered from respiratory failure due to congenital right lung hypoplasia and congenital pylorothorax. Aggressive and a prolonged treatment was required. And she also had PDA and ASD, which also contribute to the deterioration of her lung condition. So at 8 months old, when she was 3.6 kilograms, the pulmonary hypertension showed no improvement. She still needed mechanical ventilation and inotropic agents, and with this medication for pulmonary hypertension. But even if there's severe PH, the PDA still showed a left to right predominant bidirectional shunt. So PDA closure might be somewhat helpful. So she was transferred to our hospital for further treatment. And you can see the interventricular septum is flat, but with 95% oxygen and 10 ppm nitric oxide, the PDA flow turned to left to right only. That means
Dr.
she
Chen,
had good
Dr.
reaction.
Chen, I'm sorry. We cannot see your slide. We can only see your title slide. So please play. Yes. Okay.
Okay. Can you see? Can you see the slide?
Yep.
Okay, I'm sorry. So I introduced the first case. This case is born at 33. I'm sorry.
Echo findings.
Oh, okay.
Start from the echo findings.
Start from the echo finding.
Yep.
And she was transferred. Okay.
Okay.
I start from the echo finding. And you can see there's the interventricular septum is flat, but under 95% of oxygen and 10 ppm nitrate oxide. The PDF flow turned to left to right shunt only. So that means she had good reaction to primary vasodilator. So we thought she was indicated for PDA closure. And the cardiac catheterization here showed severe pH. And the PDA was type C, larger than 4.6 millimeter in diameter. And initially, we deployed 4.6 ADO-II, but you can see the aortic side, the disc of aortic side were drawn into PDA. And the pulmonary side disc was also slightly put into a PDA. So it's undersizing. So we changed the device to 6.6, the biggest one. And you can see the two discs fixed at the both end of PDA. And after intervention, there is no residual shunt, and she was transferred to a previous hospital and was discharged home 3 months later. So the second case, a boy with Down syndrome, ASD, PDA PH, who was followed up at other hospital. And the PDA was thought to be very small, so she was treated with tadalafil only for pulmonary hypertension. But at 1 year old, the CT scans showed a large PDA with 4 to 5 millimeter in diameter. And he was referred to our hospital for further treatment. So the cardiac catheterization showed severe pH as well. And the PDA was type C, 5 to 7 millimeter in diameter. And also initially, we deployed 5.6 ADO-II, but the disc protrude to pulmonary artery and the descending aorta. And the pressure gradient of descending aorta developed to 15 millimeter of mercury. So it's oversizing, so we downsized the device to ADO-244, but it's still oversized. And then we downsized to 3.4, and you can see the 3.4 ADO-II was stationary, but the device waist did not fit in the PDA. So the patient continued to have a residual shunt after procedure over several months. So we also considered the coil embolization to completely close the residual shunt. And follow-up catheter 5 months later showed only minimal residual shunt, and you can see the intimal growth in the PDA. So spontaneously closure of residual shunt can be expected. And you can see the pH improved gradually. So we decided to keep observation and continue the pH medications. So in conclusion, of course, accurate measurement and morphological evaluation by angio are crucial. But we also have to predict the property of ductal wall and evaluate the pH condition of the patient. And based on this information, you can select one best device from ADO-1, ADO-II, Piccolo, or AVP2. And especially for PDA cases complicated with pulmonary hypertension, of course, the appropriate pH treatment is very important. And if device closure is indicated, we prefer to choose devices with double disc to pinch the PDA at the both sides of the PDA to ensure the stability of the device. But sometimes we have to choose a smaller device to prevent the obstruction due to the protrusion of the device. So in this case, we have no choice but to allow the residual shunt. In such situation, the further coil embolization for residual shunt should be taken into consideration. This is my presentation. Thank you.
Okay, thank you for your excellent presentation with your interesting case. This case is open for discussion. Any question from the panelists?
Can I?
Yeah, Omar?
Yeah, morning. First of all, thank you very much to be part of this great presentations. I have a question. When you have this device inside the tubular PDA and you have significant shunt, would you not fear hemolysis? Because we encountered hemolysis when we have a significant residual shunt.
Yep.
Thank you, Omar, for your excellent question. This is Song Hye Kim.
Mm-hmm.
Yeah, how are you?
I will answer instead of YuHao. Okay? Yeah. I believe that the ADO-II or Piccolo lacks the fabric inside the device. So only the nitrogen frame mesh is only the framework. So I think it's less possibility to have a hemolysis with the residual shunt. But we have to continue close monitoring after the procedure. And if we had a hemolysis after procedure, we have to go for closure of the residual shunt with a microcoils or something.
Yeah, I totally agree that, it's hard to predict which residual shunts will have hemolysis. So if I leave the catheter with hemolysis, I always make sure to tell the parents or the nurses to check the urine to make sure there's no, it doesn't turn brown, because that's one of the key things that will show up. I've had one case where I remember a teenager, it was a small ductus, coils, closed it, no big deal, saw the patient in clinic. He looks fine, except he looked a little pale. So I asked him, what's the color of your urine? I made him go pee for me, and it was brown. And of course, we knew exactly what the problem was. So he came back and we added another coil. I actually had make one more comment. There's another PDA device that actually, it turns out to be really good too, and that's the MVP. It's called the microvascular plug. It's like a little umbrella, but like in a hexagonal shape, and it's got half of it that's actually covered by Gore-Tex, and it's actually a very good device that we've used actually for premature babies before we had access to the Piccolo device. It's meant to be implanted intraductally as well, and I think that's another option if you have access to it. Actually, the neuroradiologists are the ones who actually use it a lot for brain aneurysms. So it can go through a 4 French catheter, very tortuous vessels. So it actually can be useful also for the PDAs in babies.
Thank you. I know that the microvascular plug is also good for close the PDA, especially in the premature babies. But I think in the after the ID study in the US of the Piccolo, it takes into Piccolo after the microvascular plug. So Piccolo will be the same or better effect to have to stable and close the PDA.
My experience is that they're actually both equally effective. I have to say, I've had experience in both. The advantage of the the MVP is that you can put it right through the 4-French catheter. You don't have to exchange it for a sheath. I do think that for the very premature babies, there is a higher risk for tricuspid regurgitation when you have to exchange it with sheath. There's another device that's coming out. It's called the KA, stands for Kirk Amplats. And it's actually designed like a vascular plug, but for the ductus. And hopefully we can share some of that as well. But I think that that's another device that's going to be coming out that should also be an option for especially the premature babies.
I also hope to see you handle that someday. Thank you.
Could I say something? I mean, you did a great job with the two cases. With the ADO-II, my worry with pulmonary hypertension, that the device is very soft. So somehow I'm not so very happy to use it when we have pulmonary hypertension, but you proved me wrong. And I'm just for discussion's sake that I believe also that sometimes the plug can do the job for tubular PDA as you had. But we know that the tubular PDA is a big problem. Like you, nobody I think can say this device and nothing else works, because everybody tried different devices, and the worry is always that they can be milked out of the PDA. Just your thoughts about it, or of the panel.
Thank you, Ma.
One
We know what
audience.
you mean.
Yeah, and one audience also asked a question about worrying about the device protrusion to the LPA or something, especially when we use the ADO-II. It's a little bit larger. How about the patients? The LPA flow is okay or not?
We should have close monitoring during the procedure to prevent the LPA stenosis. So we have to change the size of the device, ADO-II device,
On the side.
at least 3 times or 2 times or 3 times to prevent it.
So how about
So we sometimes use the AVB2 to have a stable positioning of the device.
yeah, no stenosis on the pulmonary artery at all?
In these 2 cases, we have no stenosis after the procedure.
Okay, thank you.
But
Okay.
slight coarctation, stenosis of the very slight stenosis of the aortic isthmus
Okay, I see.
in both cases.
Okay,
But
now
we can observe.
move on to the next speaker. Next speaker is Dr. Jung Kim from Sejong General Hospital. She will talk about the retrieval of a tulip deformed large figular device.
Okay, let us start now. Can I start?
Yeah.
Good afternoon, everyone. I'm Jung Kim from Sejong Cardiovascular Center from Korea. I will introduce our experience of retrieval of tulip deformed large figular device. Case 1, 42-year-old female patient was diagnosed with multiple ASD and PSVT. She has no special medical history at all. Previously, she underwent RFCA for AV-NRT successfully. So she was transferred to our department to transcatheter closure of ASD. TE shows multiple ASD with flimsy atrial septal wall, and CT scan shows that major defect was located anterosuperior area, and another smaller defect was located anteroinferior area, as you can see. She underwent cath, and hemodynamic research shows QPQS was calculated to 1.7 with no pulmonary arterial hypertension. We
그건
measured.
잘 모르겠습니다. 제가 도울 수 있는 다른 부분이 있을까요?
Sorry. Shuri speak instead of me. So we measured the ball and stretch diameter with 34 millimeter sizing balloon. Balloon stretch diameter was measured to 31 millimeter by TE, 35 millimeter by fluoroscopy. At the time, there wasn't seen residual ASD shunt flow. So we choose the oversized 40 millimeter device for covered up all flimsy walls. So we performed transcatheter closure of ASD with Figulla flex to 40 millimeter using right upper pulmonary technique. Intra-procedure TE shows 2 Berkey device, as you can see, and high risk of mitral valve touching by ADA disc because of oversized device. So we decided to switch a smaller one. However, unfortunately, we failed to recapture ASD device, especially ADA disc, into the delivery stress. We tried to recapture the ASD device into delivery stress several times, but failed because tulip and copper deformity were occurred, and we had elongated this concave configuration of ADA disc like this, and for recapture. However, Figulla device was the absence of the micro screw hub at the ADA disc, so we had to come up with another way. I'm so sorry. So what can I do? In this situation, we need valuable operator armaments. Biopsy forceps shaft length was 104 centimeter. Recommended sheath was 6 French, and 6 French and 55 centimeter length guiding sheath, and so straight version because we kept the straightforward angle. And we plan to use this device through the right subclavian vein approach. The biopsy forceps bites capture the nitinol frame of the ADA disc like this, and force to elongate the device. So it was permitted to recapture into the delivery sheath successfully. So we deployed 36 millimeter Figulla device successfully. Intra-OP is also good, lesser Berkey and no mitral touching device. And next case 2, 73-year-old female patient was diagnosed with a large ASD secondary with short posterior and aortic rim with a pulmonary hypertension. So we performed first cardiac cath was underwent for diagnostic purpose, including baseline hemodynamic study and vasoreactivity test. Hemodynamic research showed that mean pulmonary arterial pressure was measured 30 millimeter mercury, and QPQS ratio was 2.1. RP was checked 3.3 Wood unit index. So we started pulmonary vasodilator and heart failure medication for preconditioning treatment. And then we considered to try to perform transcatheter ASD closure with fenestrated device. So second cardiac cath was underwent 6 months later. Hemodynamic research shows slightly improved pulmonary hypertension and increased QPQS ratio, decreased PVR. Balloon test occlusion with 34 millimeter sizing balloon was performed. We checked data at baseline before test occlusion and after 10 minutes later. ADA pressure increased from 9 to 16 millimeter mercury, and LV and diastole increased 12 to 22 millimeter mercury. It means, and also elderly ASD patient has restrictive LV physiology. So we decided to undergo transcatheter closure of ASD with handmade fenestration. T showed a large ASD device with a short posterior and aortic rim, and BOD was measured to be 38 millimeter by T and 36 millimeter by fluoroscopy. This is made by Sungho Kim. We made fenestrated ASD device like this, and 39 millimeter size Figulla device with handmade 4 fenestration holes, which were 5 millimeter each. So we deployed ASD device using balloon assist technique, and we Minnesota wiggle for checkup stability of the device position. Unfortunately, ADA disc prolapse the RA during wiggling. As you can see, the arrows, the prolapse the RA disc. And we tried to recapture ASD device into the schist, but failed because of the same reason, tulip deformation. Also, recapture was not properly performed. We tried to deploy again with the same device, but failed. Eventually, the retrieval of device became inevitable. So we tried to recapture device into the delivery schist as stronger as we can pull, but failed. So we have experienced same case before. We had a strategy and weapons for this situation. We plan to use these devices and same approach. The biopsy forceps captured the nitinol wire of the RA disc and forced to elongate the device, RA disc device. So it was effectively recaptured into the delivery schist successfully. So take-home message, it's simple. When you fail to recapture large deformed Figulla device, which has no hub in RA disc, use of biopsy forceps through the long guide schist is a good strategy of retrieval of ASD device successfully. Thank you for attention. I want to hope so you meet guys next year. Thank you.
Thank you, Dr. Kim, for your excellent presentation. Any question from the audience or panelists?
Hey, Sung-ho, it's Frank here. I don't have much experience with the Figulla device, but is this a common issue where you cannot pull the device back into the sheath?
Yeah, because it has no hub on the LA disc, so that when you use the larger Occlutech device, it happens frequently. So that we should be cautious not to make a tulip deformity in Occlutech device.
You know, with the Amplatzer device, there is a accessory wire that you can screw onto the original cable to make it longer. Is there a system where you can extend the delivery cable so that you can take out the sheath and put in a larger sheath? And maybe would that be able to pull it in?
No, because of after tulip deformity occurred, the diameter may be more than 10 millimeter at the end of the device, so it cannot retrieve into the larger sheath. So I think that the forceps using a forceps is the best way to retrieve it. Yep. Next speaker is Dr. Marhisham bin Chemud from Malaysia. He will talk about the stenting of stenotic systemic veins, postoperative mixed TAPVR repair. Marhisham, please.
Do you see my slide?
Yeah.
Do you see my slide?
We can see your slides.
All right. So I would like to thank Seung-ho and the team once again. I think it's always my pleasure to be part of this SIT meeting. And then I'm going to share with you about a patient with stenting. We do the stenting of the obstructed SVC post mixed APVD repair. Right. Do you see my slide?
Yeah, I can see your echo image now.
Okay. All right. So basically, this is a 2-month-old baby who presented with acute respiratory distress and was treated as a pneumonia at the referring hospital. The baby was not improving despite IV antibiotics. So the chest X-ray showed homogeneous opacities of both lung field. And the 2D echocardiogram was done, and it showed very diminutive LV and also supracardiac TAPVD with the obstruction at the PFO level. And there is also evidence of a pulmonary hypertension. So we proceed with the CT angiogram. So the CT angiogram confirmed there's actually a mixed type of supracardiac TAPVD, which the right upper pulmonary vein drained into the upper SVC, and the other pulmonary veins drain into the SVC and RA junction. And reconstructed images delineated all the veins very well. So this patient underwent mixed TAPVD repair, Warden procedure of the right upper pulmonary vein, and the rerouting of the other pulmonary veins into the left atrium. Post-operatively, this baby actually had a very eventful surgery, complicated with pulmonary hypertension and also chylothorax. However, he pulled through and recovered after 3 weeks and discharged well after that. The 2D echocardiogram before discharge showed unobstructed pulmonary veins, all drained into the left atrium, and good LV function. So this is, I think, the chest X-ray before discharge. So at the follow-up at 3 months, so clinically the child was well, he was thriving, and no respiratory distress. There was no facial puffiness or dilated veins. You can see the opening of the pulmonary veins confirmed into the left atrium, and RV is not dilated. Just to recap, this is a 2-month-old baby who had a mixed TAPVD repair, presented again with SVC obstruction, which shown in the echocardiogram. All right, and the CT scan confirmed that's a SVC stenosis with open up hemizygous, signify the SVC stenosis. And so we proceed with the intervention, which is the balloon angioplasty of the SVC. The first angiogram showed a pattern illuminate vein with multiple collateral from that vein as well. And SVC stenosis is significantly seen over here. This is basically at the, just below the illuminate veins. So what we did, I think the balloon angioplasty was, we proceeded with balloon angioplasty using Plachette balloon 8 × 20 millimeter over BMW coronary guard wire, which was parked at the end of the illuminate vein. So as a result, I think the procedure went quite well, and there's SVC stenosis open up pretty much quite good flow here. And then the baby actually was discharged after 2 days observation in the ward. So at the follow-up at 3 months old, clinically the child was well. He was active, being no respiratory distress, and we were quite happy and follow up every 3 months and then 6 monthly. And follow up at 3 months old, just to confirm, we did, I think CT angiogram showed quite patent SVC flow with a mild narrowing at the balloon side, which also seen clearly in the VRT images. So during the follow-up, I think a year later, this child become cyanosed. The saturation was only 76%. He shows significantly features of a facial puffiness with a significant upper body dilated veins. He's also not that friendly as usual, become more irritable and fretful. You can see obvious periorbital edema exactly like this. And on the echocardiogram showed pattern illuminate veins with obstructed SVC flow over here. And we proceed with the CT scan with contrast injected through the right arm. And you can see the contrast stop at this junction. And there's also mild narrowing of the right upper SVC. And to answer why this child was cyanosed, I think there's multiple collaterals and also hemiazygous vein which open up directly into the left atrium. So we brought the child back to the cath lab, and the first angiogram was done via left internal jugular vein using 4 French sheath and 4 French JR catheter hand shot. You can see there's a total obstruction of the SVC with multiple collaterals, venovular collaterals open up. And the simultaneous injection, So the simultaneous injection, you can see this SVC, and from the right atrium angiogram, you can see there's membranous light obstruction in between the upper SVC and lower SVC. So we tried to probe this so-called membranous light obstruction using a CTO guide wire. In this case, I think we use a Conquest Pro 9-gram tip load, and MPA-2 catheter for French was actually parked in the lower SVC as our landmark. All right, and then on the lateral view, I think probably because it was not that stable, so we used the 2 wires technique. I think 2 coronary guide wire, try to probe into the so-called membranous obstruction, and this is probably a more stable position. So this Conquest Pro guide wire was advanced through the right atrium, and you can see the angiogram at the right atrium shows that the coronary guide wire was in situ. And hence, this procedure followed by 3 millimeter coronary balloon as our initial dilation to make sure this at least open up a bit more for the next subsequent sheath placement. All right, so this is again the coronary 3 millimeter coronary balloon. You can see the obstruction over here. And this intended procedure basically actually to do SVC stenting. And you know that this child is only 8 kilogram, one year old baby. So you require a bigger sheath. So with that intention, we snared the coronary guide wire from the right femoral vein. And the 8 French Marlin's catheter was advanced. And the initial angiogram showed multiple veno-veno collaterals that was not seen in the previous angiogram. And also you can see here the hemizygous that open up into the left atrium become less prominent. So this is probably the flow is already established, even though it's probably not that significant. So the procedure started with balloon dilatation of the stenotic upper SVC. I think this is, if you remember the CT scan, just below the innominate vein. So we open up that stenosis first. So lateral view. And we use a palmagenesis stent, 1910, over 10 millimeter diameter balloon. And this was delivered via 8 French Marlins. And the placement is exactly at the obstruction site. And the stent was later unsheathed, and it was inflated to the optimum pressure. And you see here, it's opened up quite well. So this is basically covering more on the stenotic SVC side, and also so-called membranous obstruction. All right, so this is the final angiogram, which showed a good SVC flow into the right atrium, and the stent was very stable in situ. And this child actually showed a very remarkable clinical improvement. There's less facial puffiness, and subsequently subsided, and saturation on the room air was also improved up to 96%. So this is a follow-up at 6 months after the procedure. You can see the stent on the CT scan, the stent in situ with a veno-veno collateral still there, but become much less. And there's also a tiny flow of the hemizygous vein, and all the primary veins basically not unobstructed. And from on the echo itself, you can see the good stent flow, and clinically the child was also pink very well, and saturation 97% under room air. So as a conclusion, ladies and gentlemen, SVC stenosis is a known and yet rare sequelae of post-supracardiac TAPVD, especially by Warden technique, if the repair done by a Warden technique. And we knew that from some of the literature, the Warden technique is actually not recommended, especially in infants. And surgical re-repair or balloon angioplasty associated with high risk of recurrence. So in this group of patients, probably the close follow-up monitoring is very, very crucial. And SVC stenting in SVC stenosis, basically safe and also feasible to do without much complication. And utmost important, actually, the collaborative works in between our cardiothoracic surgeons, interventionalists, and also imaging specialists, especially in the care of complex congenital heart disease. So thank you very much.
Thank you, Marhisham, for your excellent presentation. Is there any questions?
This is Frank again. Very interesting case. I think your case does highlight several important things which you've included. Having done a lot of these, I found that angioplasty alone is just not enough. It could buy you some time, but we walk away thinking that we've helped. And actually, I find that unless it's purely a very discrete stenosis, I would say 99% of the time, they're going to need something that's more than angioplasty. So I would recommend just go with the stent from the beginning, because you actually then you could have avoided the extra work of having to go past the membrane and all that. And I think your other conclusion that early follow-up is really important. I totally agree. These kids can be very asymptomatic because they have the pop-off collaterals until it's so late that then they start to have other signs and symptoms of SVC syndrome. So I think that that's an important take-home point is be aggressive with just putting the stent in. But it's a great recovery there.
Frank, what kind of stent do you recommend?
Say that one more time.
What kind of stent do you...
I totally agree with you, Frank. Hello?
Yeah, so the Genesis is a good stent there. I found that for the smaller babies, sometimes your stenosis can get up to the innominate vein. I've used more of the Vallejo stents now because they're pre-mounted. And if you get the pre-mounted ones that are mounted on 9 and 10 balloons, you can go through a 7 French sheath. And if you use the ones that go mounted on 6 to 8, you can go down to a 6 French sheath. But the smaller ones cannot get to 20 millimeters. But I don't think you need to be a 20 millimeter size in the SVC. So I think that you can actually use the Vallejos mounted up to 6, 7, 8 millimeters, and they can go through a 6 French sheath.
Okay, good. Yes, Coach.
Yeah, so I've got a question. Is how do you confirm the PV, pulmonary venous root patency when you implanted for the obstructive SVC? I think this case has a warden in procedures. So you may concern the PV root as well as in SVC root.
Your question is a bit interrupted. I can't hear you exactly.
Yeah, same questions in the chat. So I think it's you have a warden procedures in these patients. So when you put in a stent large enough to open up the SVC root, that may compress in a pulmonary venous root as well. So I think it's how do you confirm is a pulmonary venous root is okay?
Actually, I think I can probably congratulate the surgeons because when we did the first CT scan, the right upper pulmonary veins are far away from the stenotic site. So with that, we don't have much problem in terms of pulmonary vein obstruction. And then the rerouting of the other pulmonary veins was well placed in the rerouting to the left atrium was well done. And then I think with that, probably we have the ample space for us to dilate the stent.
Okay, thank you. Let's move on to the next speaker. Next speaker is Dr. Kiyohiro Takigiku from Nagano Children's Hospital. He will talk about atrial septostomy by wire-assisted radiofrequency cutting. Dr. Takigiku.
Yes.
Yeah. Please.
Let me show you my slide. Can you see? Can you see my slide?
Yes.
Yes. Okay. And I'm pleased to have an opportunity to present our case. And thanks to moderator, Dr. Kim Sang-ho and Dr. Ijun Ha. I would like to talk about atrial septostomy by wire-assisted radiofrequency cutting. Atrial septostomy for restricted PFO due to the thickened atrial septum is sometimes difficult, especially in the cases beyond the neonatal period. In such case, stent implantation is required. However, it has some complication in stent stenosis, stent migration, and thrombosis formation. Kitaneto reported wire atrial septostomy for restrictive interarterial communication with second atrial septum. They made a new hole by Nicanor RF wire near internal arterial communication, then combined two holes to create a large ASD by using wire cutting. We performed atrial septostomy by wire-assisted radiofrequency cutting in a patient with restricted PFO, which could not dilate by WAS. The case is a 2-month-old girl. Body weight was 2.0 kilogram. Diagnosis was chromosomal anomaly, 1p36 deletion, which showed severe psychomotor retardation. Chen complex, coarctation about multiple VSDs, mitral stenosis, hyperplastic left ventricle, and restricted PFO. She underwent static balloon dilatation 8 months after birth. As static birth was not effective, we planned WAS before bilateral PA banding. She was candidate for future Fontan operation. In previous intervention, we used coronary balloon and steering 10 millimeter balloon for dilation of PFO. But pressure gradient between left atrium and right atrium was not changed. Before second intervention, TEE showed the pressure gradient between LA and RA was from 8 to 9 mmHg by continuous wave Doppler. This is second catheter intervention. To make a new interarterial communication, we try to perforate atrial septum by nickeling RF wire with TE guide. To make a tenting formation, we use several catheters, JR, right amplatz, IMA, and pigtail from LA side, like this. Every catheter slipped into a PFO. And finally, we could perforate successfully by left amplatz, which tip was cut. Then static balloon for new interarterial communication was done by 4 millimeter coronary balloon and 6 millimeter steering. After insertion of 5 French long sheaths, gooseneck snare with left amplatz was advanced in the left atrium through new interarterial communication. Then soft and thin 0.01 inch Asahi RG 3 guide wire was advanced all the way through PFO. And we catch RG wire by snare catheter. This is the figure of the catch RG wire. RG wire pulled out of the body to make a guide wire loop through to inter-arterial communication. Then 5 French guiding catheter was advanced on the guide wire loop near atrial septum. RG wire was pulled into the guiding catheter and long sheath with some strong force. It is so-called WAS. Unfortunately, 2 forces could not be combined. During a put septal tissue into the guiding catheter with the RG wire, we inserted the nickel RF wire to apply the energy for cutting the septal tissue. We finally combined 2 holes successfully. Pressure gradient between airway and airway decreased to 2 millimeter mercury. T shows serial findings of inter-arterial communication. After creating new inter-arterial communication, the distance between the 2 holes was 6.3 millimeter. After RF cutting, moderate size AC was created without restriction. The diameter was from 6 to 7 millimeter. This is discussion. In our case, it was not possible to strictly control the distance from the PFO to new inter-arterial communication. In small fossa bodies, it is difficult to make a second hole. We have previously experienced a case in whom was failed. In the patient, the distance between 2 inter-arterial communication was long, with more than 10 millimeter. Moreover, guiding catheter and long sheath were deformed and bent due to the strong force applied. Like this, the tip of the long sheath is deformed. In conclusion, arterial septostomy by wire-assist RF cutting was useful in creating large inter-arterial communication in patients with 6 arterial septum after neonatal period. In cases where WAS is expected to be difficult, the method of applying the energy to transect the tissue between the 2 inter-arterial communication with nickel RF wire should be considered because it is easier and safer. Thank you for your attention.
Thank you for your excellent presentation. Yeah, this case is open for discussion.
This is Frank. Hey, this was a very creative technique, so congratulations. I have 2 questions, and you might have said it, but I might have missed it. What was the energy you used, and how long did you do the RF heating? So how much energy and how long?
This energy is same as in the patient and used in PPA. Only 1 second. High output and only 1 second.
I see. And second question is that could you have done this with a cutting balloon? The cutting balloon come as big as 8 millimeters and it's got 4 blades. Would you consider that?
Yes, I also consider that. But after using a 6 millimeter styrene, the new inter-arterial communication is only 2 or 3 diameter. The size of the hole is only 2 or 3, from 2 to 3 millimeter, very small. I think the cutting balloon is expected to be it's not effective for such a small size.
Actually, Frank, I think it is forbidden to use for the largest size of the cutting balloon for the atrial septum in dilatations in Japan right now. So we couldn't use for the large size of the cutting balloon for the intersect.
I see.
Okay. Any other questions?
Yeah. Can I ask a question of understanding? Because as far as understood, first of all, it's an excellent, innovative way of doing things. Did you do arteriovenous loop to stabilize the position of the catheter? This is what, did I understood it correctly? Because occasionally the internet was interrupted in my area.
Okay. Yes, you're right.
Okay. In case you did, it's just telling you what happened to us when we tried once to balloon coarctation from the venous side. So we have LA, LV, aorta, and so on. And if you pull too much at the arteriovenous loop, we have to make sure that the mitral valve is not jeopardized. And it happened once to us that actually we created significant MR. I'm just telling you anecdotal. So it's very important when you do this loop to take care that the mitral valve doesn't get injured.
Yeah, the wire loop is from IVC to R-way to L-way and R-way to IVC.
Veno. Okay. Veno loop.
Veno loop, yes.
So it's veno. Okay. So it's veno.
Veno. Yeah.
Great. Well done. Thank you.
Okay. Thank you. And now next case is a surgical one. Dr. Charlie, please.
Hi, everyone. We are a little bit behind schedule. Anyway, we will start discussing challenge surgical cases. We have 3 panels for surgical part. I want to introduce them. Please turn your video on for audience to see your face. First panel is Kisaburo Sakamoto from Mount Fuji Shizuoka Children's Hospital, Sapien. Hi, Sakamoto. Hi.
Hi. Nice to meet you again.
Yeah, nice to meet you.
Thank you very much for your introduction.
Yeah, thank you. Next panel is Shingo Kasahara from Okayama University, Japan. Where is Shingo? Please turn your video on. Shingo Kasahara.
I'm sorry, I'm Eric Samori from Okayama University, and I heard Shingo Kasahara's internet connection is very bad, so it may be impossible to join this meeting. Sorry.
Yeah. Anyway, thank you. And next panel is Jae-geun Kwak from Seoul National University Hospital from Korea. Where is
Good afternoon, everyone.
Where is?
Can you hear me?
I can hear you, but I can see you.
Okay.
Anyway,
Can you?
Yeah.
Yes, thank you. Good afternoon, everyone. It's a great honor for me to be invited in this great meeting.
Yeah, thank you. We'll start 3 challenging surgical cases. First is the challenging case with asplenia syndrome, functional single ventricle, pulmonary stenosis, and TAPVC patients. Aili Kisamori, Dr. Aili Kisamori there?
Hello, everyone. Yeah, my name is Eiri Kisamori.
Yeah, please. Yeah,
from Okayama University.
Yeah.
And I'm glad to have this opportunity. Okay.
Yeah, please. Your audio is up now, right? Yeah, 이제.
You cannot hear the voice?
I can hear you. Yeah.
I recorded the audio, so could you guys hear the audio? No?
I can hear you. Yeah.
You can start.
Yeah.
Okay.
Yeah.
音声入力してんだろ。
そのまま口で言ったらいいんじゃない？
신고돼요?
I'm sorry, I'm away, and also internet is unstable. I'm sorry to that. And so that AD will.
AD, please.
Sorry, you cannot hear the voice. Okay.
Yes, just a presentation to the just actually.
Okay. So the patient
please go ahead.
Yeah. Okay. I'm presenting a very challenging case with asplenia syndrome, and the patient is female neonate who was born at 78 weeks of gestation with a birth weight of 2,590 grams by scheduled C-section. The patient was diagnosed with asplenia syndrome, single ventricular, common atrium, pulmonary stenosis, common AV valve canal, moderate common AV regurgitation, and supracardiac type total pulmonary venous connection. And because of vertical vein stenosis, we attempted a stent implantation in the vertical vein. However, the stent was migrated to the left pulmonary artery. 7 days later, stent removal, TAPVC repair, and CAVV repair were performed. 6 months after surgery, PVO release was performed because of progressive PVO. At the age of 1, PVO release and CAVV repair with the breaching bar were performed with stenting to left upper, lower, and right pulmonary vein. And when she was 1.5 years old, bidirectional gland operation was performed. After the surgery, she repeatedly admitted to our hospital due to heart failure. Her ECG showed wide QRS. And echocardiography showed moderate common AV valve regurgitation and dysynchrony of the ventricular. She underwent common AV valve replacement with mechanical valve and cardiac resynchronization therapy device implantation. I will show you the video. Right atriotomy was performed. Common AV valve was very dysplastic. It seems to be impossible to perform AV valve repair. Mechanical valve was inserted, supraposition of this 20mm graft to preserve the motion of the atrioventricular curtain. We use SJM Regent 70mm mechanical aortic valve. After she discharged home, her saturation was decreased gradually and complained to have headache. Her cardiac catheterization showed high pulmonary pressure and massive dilated venous shunt from innominate vein to azygos system. At the age of 5, we performed takedown of grain and modified BT shunt, and she's still in the middle of recovery in our hospital. So I will show you the video of takedown of grain. Granulostomosis was divided. And the pulmonary artery was repaired with Gore-Tex patch. A 5 mm ring reinforced Gore-Tex tube graft was selected. Proximal atrium to graft anastomosis was secured with 2 5/0 Asflex pass-ring sutures. Atrial incision was made, and the graft was inserted in the atrium using Jung technique. And then the graft SVC anastomosis was made. So we experienced a very challenging case with asplenia syndrome, TAPVC, common AV valve regurgitation, which required repeated surgeries, including mechanical valve replacement, stenting, and CRT device implantation. Without cooperation, and the passion of our heart team, we could not manage this patient. Thank you for listening.
Thank you, Dr. Kisamori. Is there any question or comment from panels?
I have a question about the pulmonary vein status. The patients received the stent implantation on the pulmonary vein.
Yes.
So I think the pulmonary vein stenosis may cause the pulmonary hypertension, and the BCPS may not tolerate. I think so. So before you perform BCPS, you check the pulmonary vein?
Yeah, of course. We check the catheterization, and I don't remember the exact date of the catheter result, but at the time, theoretically, he can tolerate Glenn operation. But after that, she experienced heart failure because of dysynchrony and AV valve regurgitation. So like after we implant stent, her pressure, so pulmonary pressure decreased.
Thank you.
I just comment. I just comment very shortly.
Yeah.
And thank you, Sonho. And this the patient did do that Glenn procedure before check to that the pulmonary artery pressure, and that's acceptable. One of that the case because of that some stenting in that cardiology do that several times to that open that, but mainly to that the pulmonary hypertension cause of that left ventricular failure, and also AV valve regurgitation, not only to that the pulmonary venous obstruction.
Thank you. Actually, we have limited time, so move. Sakamoto, yeah, please.
Okay, it's okay. It's okay.
Yeah, let's move to next.
Yeah, very. So it is difficult to say. So congratulations, but so this is very difficult case.
Right.
So good job, and hard job, but good job.
Yeah.
Thank you for your information about the very difficult approach together with the team. Yeah, very tough. That's the reason why. Congratulations, but so depends on the hard job.
Yes,
exactly. Yeah, 재훈과?
Yeah, so congratulations for the successful treatment. I have a short question. So what was your initial goal for stenting in your vertical vein? Did you want to delay some surgical procedures for this baby, or?
Yes, we wanted to delay the surgery, but we failed.
Okay. Oh, thank you.
Yeah, thank you.
Thank you.
We move to next case. Surgical option for cyanotic neonate with complete TGA VSD PS, focusing on aortic translocation. My colleague Jae-hong Lim, Sejong General Hospital. Please.
My slide.
Yeah, please.
Good afternoon, ladies and gentlemen. It is my pleasure to share our challenging case experience. Today, I talk about the surgical option for a cyanotic neonate with complete TGA with VSD and PS, focusing on aortic translocation. The patient was 4 days old female. She was born with cystic at 39 weeks of gestational age. After birth, she underwent atrial septostomy at other hospital because of cyanosis and transferred to our hospital. This is an initial cardiography at 6 days after birth. Ascending aorta located far anterior and pulmonary artery located posterior, and there was a large VSD. Pulmonary artery annular size was 5.67 millimeters, and subpulmonary infundibulum was 4.25 millimeter. Pressure gradient.
곽정생. 임종생, 그 지금
네.
잡음이 너무 많이 들리는 것 같아. 뭐 닿는 것 같아 마이크에. 대본이 닿는지 너무 잡음 심해.
알겠습니다.
Sorry.
Pressure gradient was 45 millimeters of mercury. The CT scan was done at 30 days after birth. This is a preoperative chest CT 3D reconstruction. Ascending aorta was located anterior from RV. Pulmonary artery was located posterior and size was small. Follow-up echocardiography was done at 21 days after birth. Pulmonary annulus was still small and looks like bicuspid and tethered. After ICU admission, a vital sign was stable and initial SpO2 was 75 to 80%. SpO2 was slightly decreased, so we supply oxygen and give propranolol. Fortunately, we can manage the patient with oxygen and propranolol until 6 weeks of age. At 6 weeks after birth, the patient has had frequent desaturation event, so we decided to do operation. The patient body weight was 4.1 kilogram. We considered some options to treat this patient. First option was pulmonary valve balloon valvuloplasty and observation. If saturation was maintained, we can delay the surgical decision and observe pulmonary valve growth. Second option was VT shunt first and late total repair. Third option was total repair. Austria group reported their experience of a complex transposition with en-bloc rotation. They analyzed 19 patients with TGA VSD PS or similar anatomic characteristics. If patient had no doctor-dependent circulation, they planned elective operation at age between 6 weeks and 3 months. At the age of 38 days, a follow-up echocardiography was done, and pulmonary stenosis was not improved and had a frequent desaturation event, even though medical management. So we decided to do total repair. Operation was conducted at age of 42 days. A body weight was 4.1 kilogram. Total CPB time and ACC time were 308 minutes and 179 minutes. Great arteries had an AP relationship. Coronary artery was the usual pattern. After aorta cross clamp, ascending aorta and pulmonary artery was transected and inspected. Pulmonary valve was bicuspid and tethered. Aortic valve was okay. Both coronary button and en-bloc harvest of aorta pulmonary trunk was done. After inspection, half-turned trunk was anastomosed to trim the root. After aortic trunk was anastomosed to posterior to the root, VSD was closed with the fixed autopericardium. Pulmonary valvotomy and tethered relief was done and anastomosed to anterior part of the root. Post-operative course was smooth and the patient was discharged at post-operative day 8. Follow-up CT scan was done at post-operative day 7. Aortic anastomosis site and pulmonary anastomosis site was okay. Latest echocardiography was done at 3 months. There was some mild AR and ascending aorta size was okay, but pulmonary artery and valve size still small. In case of not suitable to arterial switch operation and LVOT relief in TGA VSD PS, aortic translocation can be a reasonable option even in the early infancy, but long-term follow-up is needed. Thank you for your attention.
Thank you, nice presentation. Is there any question or comment from panel? Yeah, Sakamoto.
Thank you. Thank you very much for your great information about the aortic translocation. And it was a very good job and a brave job. Anyway, so I would like to get one information about the pulmonary valve. You rejected completely the pulmonary valve. And how about the size? How about the diameter of the pulmonary valve? Because we have to consider which is better. So just aortic translocation without complete rejection of pulmonary valve, sometimes the half transgress each other. And if the pulmonary valve size is small, at the time, just Nikaido, without complete rejection, together with the coronary rejection, just move the posterior side of the rejected aortic valve, original Nikaido. How about the size of the pulmonary valve?
Dr.
Pulmonary
please.
Diameter.
Pulmonary artery diameter was 3 or 4 millimeters in the operating room. 4 millimeter Hegar dilator was passed from the pulmonary valve.
Anyway, anyway, in these patients, actually, pulmonary valve is small, but anyway, we saved the pulmonary valve so far. But we don't know because the patient's pulmonary stenosis, some progressed. So I'm worried about that.
Anyway, so my point is, if the pulmonary valve is small, within 5 millimeter or 3 or 4 millimeter, at the time, just the original previous Nikaido procedure, just moving to, just let aortic valve move to the posteriorly.
In that case,
without coronary valve blockation.
Yeah. So in that, we want to save the pulmonary valve, we can try to aortic translocation, but we can sacrifice pulmonary valve because it's too small. We can do the knee guide operation. In these patients, I think this pulmonary valve annulus is not too small because we can save them. Yeah.
Okay, so another one question.
Yeah.
How do you decide to use pulmonary valve totally? Because sometimes the rejection of the pulmonary valve has a risk to injure left side or posterior atrioventricular valve. How do you decide pre-operatively and during the operation?
I can hear you.
Very sorry.
Yeah.
Sometimes we are afraid of injuring the mitral valve.
Yeah. Actually,
How
I
do
can
you decide?
Yeah.
Pre-operatively
in these
or
patients,
during operation?
Yeah, in these patients has some fibrotic ridge between our pulmonary valve and the mitral valve. So in this case, we can move the truncus safely, avoiding mitral valve injury. Yeah. Thank you.
And so your decision is pre-operatively or not?
Pre-operatively.
Pre-operatively?
Yeah.
Oh, is it true? Oh,
Yeah.
Great information. Thank you very much.
Yeah, thank you.
Actually, this case has a very debate with our pediatric cardiologist team because the age of the patients is too young, only 40 days old. So in pediatric cardiology team recommend balloon valvuloplasty first when the patient shows desaturation, and wait several months. Then we recommend after 3 months, please do that. But Charlie did not follow. How about you? Is the time is good for aortic translocation in neonate?
Not neonate, actually.
Yeah. Depends on the surgeon's great skill. Did it.
But
thank you.
As you can see, the aortic regurgitation occurred, So we should be cautious to perform aortic translocation.
By the way, so I have a question to the interventionist, Song-ho.
Yep.
And this patient had a small pulmonary valve, 3 to 4 millimeter in diameter, pre-operatively. Yeah.
But pulmonary portion is okay.
Do you consider it's effective or not?
Yeah, so
it will be effective.
Yeah. Usually TGA VSD PS patients shows the combined PS, but in these patients, no subpulmonary stenosis, only valve portion. So when you perform balloon, it may be increased in size as time. So we may consider the arterial switch operation. I don't know, but we may perform arterial switch operation instead of aortic translocation.
Yeah.
So
great discussion.
Just the balloon and wait, and we can observe.
Yeah, thank you, Ian and Sakamoto. Move to the last case. Last case is a 7-year girl with advanced aortic valve repair with three-cuspid ripple extension, early and late result. Hiroki Ito, Dr. Hiroki Ito from Shizuoka Children's Hospital, Sapien. Please.
Good afternoon. My name is Hiroki Ito, working with Dr. Sakamoto right now. And as he announced last night, sometimes we would love to share an information of a case of aortic valve repair using leaflet extension technique on a pre-adolescence and its consequence. The case is, now we are preparing the slides right now.
Still moving, no? Yeah.
Can you see this slide?
Yeah, we can see.
Okay, thank you. Okay. The case is a 7-year-old girl. She had no symptom, but severe aortic regurgitation with dilated left ventricle. The echo showed there were retracted cusps without coaptation height. So she has severe regurgitation coming from posterior commissure and the center of the valve. The left coronary cusp is small, and the right coronary cusp and non-coronary cusp was fused, creating a raphe. As you can see right now, she has more than 240-degree bicuspid aortic valve. The valve annulus was 21 millimeter, and the sinotubular junction was 31 millimeter. Pulmonary valve also had mild regurgitation as well. So the surgical repair, after we discussed with her family about how to treat the valve, we decided to do the aortic valve repair using cusp extension or whole cusp replacement. Our target cusp height is to be annular size, and the free margin length is to be 1.4 times of annular size, as you can see right now. So after cross clamping, the aorta was opened by a transverse excision. Okay. Approximately 8 millimeter above the sinotubular junction, and cardiac pressure given again. So the commissures were placed under radial tension using state suture. Please make sure keeping the sinotubular junction upward and outward to imitate the diastolic phase and pressure. Then we inspected the cusps. There was a small left coronary cusp, but that had well elasticity. There was fused right and non-coronary cusp, as you can see right now. The aortic ventricular diameter was measured by intubation with the sizer. The size was 19 millimeter. The geometric height of the left coronary cusp was 12 millimeter, and the effective height was 3 millimeters. So we decided to do the cusp extension technique using pericardium. We cut the pericardium out to make up a 21 millimeter cusp, thinking the margin of suture line. And sew it up using ADO-II running suture, as you can see here. So we treat it with 0.6% of glutaraldehyde, and we usually treat it for 3 minutes. And then we also cut the fused valve and partially took that out. The remnant size was 7 millimeters, so we made up the cusp up to 21 millimeter as the same manner. So we thought the free margin was a bit longer enough, so we put a central application respectively. And then I put a commissure alignment suture without pledget. The effective height was 10 millimeter. And we also created the newly commissure. Post-operative echo shows the valve opening was good enough. As you can see right now, there are longer and higher cusps and no regurgitation. Please make sure the sinotubular junction was also reduced by plication of the ascending aorta. 5 years after the aortic valve reconstruction, aortic regurgitation has been gradually increased, although aortic stenosis is moderate. Please make sure that the valve length was shorter than that of before, and also the free margin of those cusps were retracted. Those cusps were thicker than that of before. As a consequence, there is a big gap in the central portion, making a large regurgitation. We thought the pulmonary valve was not suitable for Ross procedure as she had a PR. After talking with her and her family, we decided to put a mechanical valve. After cross-clamping, made a partial transaction, then cardioplegia given. Dr. Sakamoto scrubbed in at this point and checked the valve. As you can see right now, there were calcified cusps. Those free margins were clearly shorter than that of before, and those cusps margins have no elasticity. Sakamoto took that out carefully. The cusp was very hard. And checked it. There was the native tissue with calcified pericardium. Also, there was fibrous tissue on the native valve, as you can see right now. And we peeled off and checked the native valve. This is the valve. The native valve. And that is the pseudo-intimal tissues on the native valve. Subsequently, we took other cusps out and carefully inspected. This is the right coronary cusp. Used to be the worst cusp. We thought those native cusps didn't grow enough, but the annulus has grown after resected residual tissues. And then Dr. Sakamoto scrubbed out and said, "You are in charge. I'll leave it up to you. Bye." So we put 21 millimeter Onyx valve, Onyx mechanical valve, as you can see right now on the superposition. She discharged an event-free, and we have discussion point. So there are many issues in there for a better outcome when we do the cusp extension technique. So the cusp design would be one of the most important points I think. So the cusp height, meaning geometric height, normal cusp height would be about 20 millimeter based on these published reliable data. So we use the annular size for the target cusp height. On the other hand, cusp free margin length would be about 1.8 times of geometric height based on this paper published by Belgium group in 2018. We have used 1.4 times of geometric height for the free margin length classically. So based on those findings and experiences, we need to refresh the strategy continuously to get better outcomes. Thank you.
Thank you for nice presentations. Dr. Kwok, can I ask a question or comment?
So you guys put the mechanical valve in this patient's second operation. How about putting how about applying the Ozaki technique or the leaflet extension again at the second operation? The patient is still young, and I think she will be married to some guys. So
yeah,
you have a good result. Almost 7 years with your leaflet extension technique. I think the patient is already grown up, and the leaflet extension will be more effective at that age.
Yeah, thanks for your question. Yeah, of course, we offer options about Ozaki procedure and bioprosthetic valves and mechanical valves before the operation, but the family and herself wanted to put the mechanical valve to reduce the reoperation. That is the reason why we choose the mechanical valve implantation in this case.
Yeah, can I have one? So adding response? Yeah, is it okay?
Yeah. Last one, yeah.
Yeah. Anyway, so it was true. Dr. Ito so informed about that. But so if we have or we can use the more effective, innovative tissue sheet at the time, so maybe I would like to recommend the possibility to make Ozaki procedure. However, so you watched the result of the treated glutaraldehyde treated pericardium, so thickened and calcified within 5 years. That's the result. And I would like to try to get the innovative seat. And how about the Korean seat made by Yeonji Kim?
Yeah.
Is it effective or not?
Actually, we don't much experience about that. Actually, we waiting the result using that kind of pericardium, right? Thank you.
Yeah. So now, so in Japan, or in our institute, we can use just the xenomedical or so bovine or, but so not so very effective to make a longer, better result after so these operation, including the Ozaki procedure in our experience. That's the reason why. But so 5 years, it was not so bad. So body weights came from the 25 kilo to more than 50.
More than 50.
And the size of the aortic valve is 90 millimeter in diameter to, after resection, 23 to 4. Yeah. And we could put the mechanical valve diameter in 21.
Yeah.
So it was one of the choice, but so I'd like to get so information about opinion or consideration, Connor or others.
Yeah.
So if we can make a Connor procedure at the 25 kilogram, at the time we could give the so mechanical valve 23 millimeter or 25. I don't know exactly, 23 millimeter in diameter. It was true and it is true. How do you think about that? So, Chen, how are other surgeons?
Actually, yeah, I agree with you. Yeah, what valve size in terms of valve size. How about Jae-geun? It's okay. Yeah, actually, we are really behind schedule, so I like end these sessions, right?
Yeah. Actually, this session is a challenging case competition. So the winner is supposed to have $300 award, but we changed. Every presenter can have $100. Okay, is that okay? Because of the first year by a webinar, so we do not have enough time to vote. So I will give each presenter $100 bit.